in 4 years of graduate teaching.
Sorry.
You're not in it.
Okay.
Just your coffee is.
Yeah, that's right.
No,
Oh my
Yeah,
god,
come
am I
back here,
actual
Casey.
like names
Yeah,
gonna be
maybe
here?
I'll move back further.
so that I'm not to distract your video. Sorry.
I would have liked if it was anonymous, I guess.
Make up a name. Then it'll be anonymous.
Oh, well.
It is I think it is anonymous.
No, I'm
Should
responding
be.
as Kimmy Conlon.
Or you could just put initials or.
I just did my name.
And then 3 people have started it. Isn't that cool?
It's really cool. Oh, nice.
Yeah, I think it is. And I wrote these questions, so if they don't make sense, don't beat yourself up. Hi. Did you come to watch?
Yeah, we came to watch, so we'll come up that way.
Yeah. Comfy seats up here for you. Hi. I'm Malia.
I am Barbara.
Hey, Chelsea. Hi, Chelsea. Thank you for coming. I was hoping nobody would show up and I could just do this to an
Well, not with Phil. You can't do it with Phil. Where's
I
he
know.
at? Is he coming?
No, he's not going to be here.
Are you kidding?
I know. Hi, Kaylee. He's doing nursing orientation today, but this was like the best day for
Supposed to be there.
clinical students.
Hey, Tim.
Hey.
Are you still standing?
I had to get away from my unit after I just lost my cool.
Oh.
He sent me an OB scrub tech to cover suicidal 1-to-1 who's not trained, and the guy tried to hang himself. So that's the kind of day I'm having.
Okay.
I'm like, I gotta go.
Yeah. You need to
I
detox.
need to walk away from this.
So they're just doing a quiz that I wrote, and then this is how far they've all gone in the quiz. And then we'll go over the questions and the answers at the end. That's my plan anyway. Tammy, did they have you do something like this?
Yes. Just think this way. You're almost there. You're almost done.
I think the
I
majority of
have
people.
PTSD sitting here, but you're good.
I think the majority of the people in this room will be in your boat one day. They're all nursing students, right?
Yeah.
Yes.
So be kind.
Great.
I'm sure.
At the end, you guys are going to be like, that was it? Okay. Or maybe we'll go over the quiz in the beginning, just because I'm not sure if I'll be able to leave and come back into it. Oh, yeah. Just a little handout for, it comes up in like the middle of the lecture.
Here, actually, did we already have one? I suppose.
Just going to start to go over the results. So the first question on the survey is which of the following statements made by a patient family member would indicate the family member needs further teaching? So looks like 36% of you said my father can still get surgery if he's on palliative care. And then, but the majority of you said when my father goes on hospice, he can continue to see his PCP for care. So the right answer is C, but we'll go over that in my presentation. So it looks like a lot of you got this one right. Early referrals to palliative care can decrease costs to healthcare. And you might think it would decrease length of patient's life, but it actually increases the length of their life. When an actively dying hospice patient comes to the emergency room, what action should the medical staff refrain from? It looks like a lot of you gave put opiates for dyspnea. That's actually one of the ways that we treat dyspnea in the actively dying patient is we give opiates. And placing an indwelling catheter, it might sound painful, embarrassing for the patient, but if they have really bad bladder distension, this can be a way to alleviate some of their pain. And everybody thinks we should give anti-anxiety medication, so that's a good answer. And then the correct answer for this question is to give IV fluids for hydration, and we're going to go over that in the handout that I gave you guys. The next question is, which of the following questions is inappropriate regarding end-of-life goal conversations? Why do you guys think B is the right answer? Anyone? It's okay if you're wrong. I'm getting graded here, not you guys. So, go ahead.
The way that I thought about it was like, you never want to define palliative or hospice as we're not doing everything we can for you. You want to do it, you want to pose it more like we're doing everything we can for you and more by providing this team. And so if you ask, do you really want us to stop care? Then that can give it like a negative connotation.
Exactly. So all these other ones are really like hopeful, positive questions. How do you define quality of life might be a way to start a conversation about palliative care. But do you want us to stop aggressive care? It's like saying to a family member, do you want us to not do everything that we possibly can to help your family member? They're always going to say yes. So it's a very negative statement for the family. And this is the last question, and you guys almost all got it right. I'm very impressed. So, which of the following diagnoses do not warrant a palliative care consult? So, do you guys know why heart failure? Some of you have had some lectures on palliative care, so I'm hoping that's why you all got this right, because I didn't know this. Why would heart failure get palliative care? Anyone know?
Is it a terminal diagnosis?
Right, it's a lifelong, life-limiting diagnosis. They're going to have it forever, and we're going to talk about the goals of palliative care and what they can do for a patient like this. Lung cancer, you guys got. COPD is a lifelong illness, but myocardial infarction, hopefully we can get them all fixed up and get them out the door. So that's good. You guys did pretty good. Either my test wasn't that difficult or you guys are very smart. Okay, so I've been a nurse for 10 years. 3 years I worked on a telemetry unit at Jefferson. And then for the last 7 years I've been in the ER over at HUP. Hi, thank you for coming. I've been in the ER over at HUP. So I thought this would be a really good presentation because my practicum is with Phil Landis, and he's the educator in the ER. So he really wanted me to talk about something that pertains to my practice. So we see palliative care and hospice patients in the ED sometimes. And does this seem like it might not be the place where you would find these people, right? Because in the ER, these people are coming in for broken bones or they had a heart attack. So why would a palliative care patient be in the ER? Can anyone think of a reason that a palliative care patient might be in the ER?
They have like respiratory distress and they're brought in because they can't breathe, and then you need to do like extraordinary measures to help save them.
Right. Go ahead.
Maybe if they like fell at home and then they also like broke a bone similar to other patients there.
Exactly. So it can be a big, it can be very emotional for ER nurses because we're just trained to jump in there, save people's lives, and then now we're getting patients who are maybe actively dying or are on palliative care or hospice, and we're kind of like, well, why did you come here? So it can be like a very emotional experience for ER nurses. So I thought this would be a good way to introduce the topic to you guys about what's the difference between palliative care and hospice, and then what we do about it in the emergency department, why you see these people, what do we do for them, and I also gave you at the end some tips on what to say to a patient when they express an interest in palliative care. So I have 4 main objectives. We're going to talk about palliative care and hospice care and what the difference is. There's a very defined difference. We're going to talk about why early referrals to palliative care from the emergency department, why they benefit patients. We're going to discuss ethical and legal principles of palliative and hospice care in the ED. And then we're going to formulate some phrases to use when a patient expresses interest to you in palliative and hospice care. So, what is palliative care? Just shout it out. What do you think you know about it? What have you heard? What is palliative care? Go ahead, anyone.
It's like providing comfort care, but it's different from hospice because you can perform life-saving measures.
Yes, exactly. So, palliative care, it's a multidisciplinary treatment team, and it starts at the time of diagnosis. So if somebody gets diagnosed with cancer, they can get a referral right then for palliative care. And it ends when the patient goes into hospice. So when a patient is under palliative care, they're not in hospice yet, but it can be from the start of their diagnosis. It includes a whole team of people, and these people are especially trained in having these conversations about meeting end-of-life goals. They're just really good at talking to patients about what they want for their future. And it includes a team of doctors, nurses, dietitians, social workers, psychologists, massage therapists even, and chaplains. The whole goal of palliative care is to just help the patient meet their goals. So if you were diagnosed with a terminal illness, God forbid, but if you were diagnosed with it, what do you think your goals might be? Like if you found this out today, what would you want for the next couple years? Go ahead.
Like be able to spend time with family and friends and be
Yes.
present when doing so.
What else?
I would just want to be as happy as possible in the time that I had left.
Anybody else?
I think I'd want to not be in pain.
Yep, so those are all like the big popular ones. I want to spend as much time with my family. I want to not be in pain. And I forget what you said.
But I said just like happiness.
Yeah, you want to be happy. So palliative care will also identify early when the patients are no longer meeting these goals, and they'll help to talk with the primary treatment team about, is it time to withdraw treatment? So these doctors and this team of people, they're really good at talking to people about this. And they will refer a patient to hospice when their time comes, and it gives patients a longer time in hospice. I was doing some research for this project, and they found in about 10 years ago, they did a study that people who, 30% of people who died were in hospice. So if these people are going to die anyway, but only 30% of them were actually getting hospice care. So they were maybe dying in like a traumatic way in an ICU or in the hospital, as opposed to getting hospice care at home. And yeah, that's it. But on palliative care, these people can still get curative treatment. So they can still get chemo, radiation, surgery, like life-saving treatment. They can still get it. A lot of people don't know that, so I'm very impressed you guys did know that. Hospice care, though, is for terminally ill patients. It's on a state-by-state basis, but usually agreed upon by 2 physicians that the patient is within 6 to 12 months of death. And they agree at this point that treatment is no longer being pursued, and we're focusing on making the patient comfortable. It's done at home, in the hospice unit, or in a hospital. And I reviewed Medicare Services gives like a pamphlet to people when they're thinking about hospice, and these are some of the benefits that they get. I thought this would be cool for you guys to know. They get a doctor and a nurse on call 24 hours a day. They get medical equipment, and this stuff is free for them. Medical supplies, prescription drugs, they have to pay like up to $5 for a copay, and they get 5 days of respite care. Do you guys know what respite care is? Go ahead, what do you think it is?
Oh, like for their caregivers to give them a chance to like get away and rest, so someone else be like coming to the house to care for them during that time.
Right. So it can be exhausting if you're living with a family member who is within 6 months of death, and you're there for them every day, you're taking care of them, you're doing all of like their emotional supportive care, everything you would do for a family member that you had that was passing away. But sometimes this is so exhausting to family members and they just need a break. So the hospice benefit from Medicare will pay for you to put your family member in an inpatient hospice unit, so they're still being taken care of by doctors and nurses, but it lets you have a little bit of a break, which a lot of families really need. So hospice will not pay for treatment to cure your illness. It won't pay for prescriptions other than symptom control or pain relief. They won't pay for a doctor that wasn't arranged by the hospice team. So if you go to an oncologist and you say, is there any other last treatments that I could get before I go? They won't pay for that. They won't pay for room and board, and ER visits or admissions into a hospital they won't pay for. So this can really rack up a lot of costs for these people at the end of their life. So real quick review, what's the difference between palliative care and hospice?
Palliative care, you can do curative treatments, but hospice you can't.
Right. So palliative care, think of it as like layering on, putting a layer on traditional care. So they're seeing both their primary care doctor, they're seeing their oncologist, but they're also seeing a palliative care team. And in hospice care, all that stuff ends and they're just under the care of a hospice physician. And I have a little video for you guys in case you're tired of hearing me speak.
I'm gonna cry.
10 with
It's only 2 minutes, so you're not going to be here forever.
Sarah and John Ratzenberger were barely through their honeymoon when the symptoms began.
it started in January of 2010 with a cough, and they diagnosed with pneumonia.
The cough didn't go away, and 6 months later, surgery to remove a lemon-sized tumor revealed the startling news.
On July 23rd, 2010, my wife Sarah was diagnosed with stage 4 lung cancer.
Suddenly, this 31-year-old avid runner who never smoked was in an unexpected race against time.
It was less about curing the disease than it was prolonging her life and doing what we could to try and treat and just make her feel better.
And that's where the Stormontville Cancer Center's palliative care program stepped in to help.
Just as hard as they're fighting to fight their disease, they want to fight just as hard to feel good. So our main goal in palliative care is to help patients feel the best they can feel every day.
Program coordinator Robin Holthouse says palliative care provides an extra layer of support for patients with serious illness. The team includes doctors and nurses who serve as a central point in coordinating care, not just physical symptoms, but also emotional and spiritual needs.
And we spend as much time as needed to answer all the difficult questions. We talk a lot about goals of care.
In Sarah's case, John says it was Robin who, a year into Sarah's treatment, noticed unusual side effects and insisted on an MRI that revealed cancer had spread to her brain.
They discovered that she was able to get the radiation treatment, and so she had another almost year and a half after that.
It was time they used to travel and enjoy life. Sarah died November 8th at the age of 33. John credits the palliative care team for leaving him at peace with his memories.
She was an amazing, amazing person, and I can look back and I see how strong she was and what she went through. But it also gives me the chance too to not just see Sarah as a diagnosis or me seeing her as somebody that I gave support and care to. I get to see her as my wife, and that's the important thing.
Melissa Brenner, 13 News.
Okay, so one thing I thought about when putting this presentation together is you might think, well, why couldn't the regular doctor handle this? Like, some people might really love their primary care doctor, they might really love their oncologist, So I wanted to do some research into why palliative care really benefits patients. So this is a huge pivotal study, and I've been getting emails about this through mid-page. So they did a study on these patients that were diagnosed with metastatic non-small cell lung cancer. Half of them just got regular standard oncology care, but the other half of them got standard oncology care and palliative care at the same time. At the end of the study, they looked back, and these patients who received palliative care and oncology care had reported a better quality of life, a better mood, they had less aggressive treatment overall, and they lived longer, which I just think is crazy. You know, that's like our whole goal of treating someone with cancer is to try to get them to live as long as they can. And even though they both got the same oncology care, those with palliative care lived longer. So that triggered this recommendation from the American Society of Clinical Oncology. So they now say that all patients who are diagnosed with metastatic non-small cell lung cancer get a palliative care consult at the time of diagnosis because they think it's so important to improving the quality of lives of these people. On the other hand, it also saves everybody money. It saves the hospital money, it saves the patient's money. They did research that if a patient got a palliative care consult, I'm sorry if you can't see this in the back, in 6 days of admission, they saved about $1,300, and if they got it within 2 days of admission, they saved almost $2,300. So it's a decent amount of money. It's estimated to be about 14 to 24%. So I was actually in a big research study for HUP to try to trigger palliative care consults from the emergency department, because if you're saving money at 2 days, imagine if you were able to recognize these people in the ED. You might not start the conversation, but you would at least say, hey, I think this might be a good idea, and get the doctor to just call palliative care to come down and speak with these patients. So they've really tried to start doing this even from the emergency room. So what does palliative care do for patients? We talked about this, but just to review, it improves quality of life for both the patient and the caregiver. It increases their survival. It improves their symptoms. They will be referred to hospice earlier. It lowers their healthcare costs, and it reduces depression. So in general, all good things. And just think that the earlier you refer a patient, the more benefits they receive. So if they get referred to palliative care sooner, they get to reap more benefits. So then how will this affect you in the emergency department? We already talked about this, like why these patients would call 911. So these patients are at home with family members, and they might have what was expected with their diagnosis. They might suddenly become short of breath. They might have really worsening pain, and it scares the family, and they call 911. This happens all the time. Patients might have a terminal illness, and they're scared, and they don't want to die, and they have a last-minute cry for help, and they say, call 911, I don't want to go. I've taken care of people like this before. It's heartbreaking. Or they're calling 911 for something other than their terminal illness. So they might be at home on hospice, but they fell and they broke their hip. So they can't, that's causing worsening pain. Or they might just be really stressed and having difficulty coping with their loss of life. So I have these 3 instances that I wanted to talk about. So what do you guys think would happen if a patient is on hospice, but they call 911 because they're choking? So they have a DNR, or even if you're in the hospital and your patient is on hospice and they're DNR and they start choking, what do you guys think we should do?
Help them.
Yes, but help them to what point?
Not to the point of chest compressions. Like, try and dislodge the food.
Yeah, so you would think about, is this a reversible setback? Is this something we can fix? And this has happened in the ER a lot recently. A hospice patient might be dying and everything seems to be going normal, but now all of a sudden they have a stroke and they can't swallow. So what's bad if they can't swallow? What do you think a hospice patient might need?
Food and water.
Food and water. Trach, yeah. They might need pain medicine, and now all of a sudden they can't swallow because they had a stroke and they can't get their pain medicine. So
Would you train somebody that was on hospice care? No, you wouldn't.
no, we've had a couple of situations just like this, and you try to do the best you can to stop them from choking, but at a certain point, usually you bring the family. We've brought the family in and had a goals of care discussion and just make them comfortable.
But they're aware that they're on.
Yeah. Yeah, they come in with an advance directive and everything, and the families are there. This one is really cool. So your patient has DNR tattooed on his chest. So what do you guys think would happen in this situation? What if you are just like walking down the street and you're a good Samaritan and all of a sudden this guy stops and drops dead in front of you and you pull his shirt off because you're a nursing student and you're going to save his life and you see this tattoo? What do you do? Is this legal? Is this going to hold up in court?
No.
Yeah? Depends. Yeah, it's true. What do you guys think you would do?
Signed tattoo.
Maybe this will happen to you. You guys are like all
Would
new
they have
nurses,
would
so-
they have documentation to go along with said tattoo on them?
Yeah. Well, I mean, theoretically, you wouldn't be seeing that tattoo unless you were going to do CPR. So, what do you think?
I feel like I would still help them because what if they got that tattoo when they were really young and just never got rid of it?
And
or thought
drinking?
it was
Right.
funny or something. I don't know. You're kind of assuming either way, but if you don't save them and it was a joke, then it's like it's kind of a balancing decision. But I think
Yeah.
I would save them. I know I would save them. Try to.
All right. So, I printed out this article because I thought this was so cool. And this was on the news last year. I remember seeing the picture. This is not the article that I sent you guys, but that's in front of you guys. That's something different. But this situation happened last year. And I believe it happened in Florida, of course. So the story is an unconscious 70-year-old man. His only medical history is COPD, diabetes, and AFib. I bet you guys have those patients with all of those diagnoses on your units. And he came to the ED with an increased blood alcohol level. And while he was in the ICU, his blood pressure dropped and he became acidotic with a pH of 6.81. He had no ID and there was no family with him. And they kept trying to address because he was just completely unconscious. They couldn't arouse him. And then, when they're getting him on the heart monitor, they find this DNR tattoo. So it raised up a lot of ethical questions for them in the emergency department and in the ICU. So for this hospital, who do you guys think you would call if you had like an ethical dilemma like this?
Ethics, board of ethics.
Yes. You guys are so smart. I was like, oh, they're never going to get this. Right, so they called for an ethics consult. They gave him antibiotics, IV fluids, and they started him on vasopressors, and they put him on BiPAP. But they decided that this was a pretty, it's pretty serious the way he had it put on, and they decided to honor it. Also, at the same time, they sent social work to his house to break in to see if he had new paperwork. So eventually they were able to figure out who he was. Social work broke into his house. They found the DNR order, and then he was allowed to pass away. But yeah, I thought that was really cool. But you're right. In the end of this article, they do say that they don't think the doctors who wrote this was the New England Journal of Medicine, so they wrote this correspondence to this journal. They have no opinion on this. Obviously, they want a formal document. They don't think this is a good idea. They don't think it's a bad idea. Why would this be a good idea?
miss it.
Yeah, you're not gonna have anybody accidentally give you CPR, but it's gonna really
So
frustrate your
is it
nurses.
state to state, or what is does anyone know?
I don't think there's a formal. Because you're right, you could just be drunk one night and get this done,
Yeah.
and then not.
It also raised the question, though, at least. Like, if he didn't have it, no one would have gone to break into his house to look for DNR papers. They would have just saved him.
That's a really good point. I didn't think of that. So. Well, that was kind of cool. Anyway, so if you guys end up working in the ER and you get a hospice patient, there are published like step by steps what you should do. Number one, you're going to notify the hospice staff as soon as possible. Does anyone know why? You guys are so smart.
Well, aren't they supposed to, like, you can come off hospice and then so that you can get treatment while you're in the hospital and, like, get it paid for and then you can go back on?
Close. So the hospice doctor is the one who decides what gets paid for. So Medicare, at least, won't pay for it unless the hospice doctor planned on it. And then you're going to determine the trigger. So why did they call 911? You guys already discussed this. Their feeding tube might have fallen out. They have a new illness or they're scared. And then you're going to treat the most distressing symptoms. So if they're short of breath, we're going to give them opiates. If they're really anxious, we're going to give them anxiety medicine. And then have a good discussion about goals of care. And I just put in here, your compassion and patience here can change the whole course. So a lot of times my colleagues in the emergency department, we just get frustrated. Like, why? Why do I now have to do this? Like, you had this whole treatment, you had this whole thing planned out, and now you're here. Like, why are we doing this? But we just have to remember that this is, like, the worst part of their lives. They're terrified, and they have the right to call for help if they need it. And they have the right to change their mind. Address spiritual needs. So who are you guys going to call? Chaplain, right? And limit labs and diagnostic tests. Do you guys know why?
So you have to act on the results. You take
Yeah.
the test, you have to act on it.
Right. Why do a test if you weren't going
Right.
to do anything about it anyway? What's another reason why?
Is it because they're invasive?
They're invasive, yeah. You wouldn't want to draw blood on somebody who's dying. It's painful.
You also can't get IVs, so if you're, like, taking a lot of blood, you're depleting their blood volume, and then they probably can't get pressors, they can't get IVs.
Right. What else?
And they cost money, so
Yeah.
hospice probably wouldn't cover
Yes.
that.
Yes. That was what I was thinking when I wrote the slide, but you guys are all right. But yes, also, labs are very expensive. So hospice doesn't want to pay for labs that you're not going to act on anyway. Totally futile. Anyway. And then we're going to discharge them back to inpatient hospice, home, or increased caregiver support, whatever they might need. And then I gave you guys all a handout about what to do when a patient is actively dying, and I thought this was really interesting. You guys have and this is just for your own. So you guys are nursing students, so hopefully you'll have somebody with you a colleague with you who knows what they're doing when the first time this happens to you. But these are some considerations why we do things and why we don't do other things. So if a patient is refusing to eat or drink, it says here, don't start IV fluids, which if you have a patient who hasn't eaten in days, hasn't had anything to drink in a few days, it can be heartbreaking to you because you're feeling like you're letting them starve to death. But as they become dehydrated and as they don't eat for a few days, their brains release these endorphins that provide comfort. So it's actually like a totally normal thing to not want to eat or drink. And your brain responds to that in a way to provide you comfort in your, this is like actively dying. This is like the very, very end. So you can do mouth sponges, you can do ice chips, but you're not going to force them to drink. give them blankets. For people who are unable to urinate, you're going to put in a Foley to relieve the pressure if that's painful to them. Does anyone know why you give opiates for shortness of breath? Go ahead.
Doesn't it make it easier to breathe? It kind of works the same way as like an anti-anxiety med.
Mm-hmm.
It like relieves the difficulty of breathing.
Yeah, how? It what?
Relaxes the muscles
Mm-hmm.
in the lungs so that you're not getting trapped there. Or...
Right. Anything else? Go ahead.
I might be getting this confused, but is morphine a vasodilator too? So you get more blood and oxygen.
I think so.
Doesn't it like depress the respiratory center in the brain so they don't take as many breaths as well, and
Right.
so it's not working them as hard?
Right. So you guys remember Mona, right? When somebody has chest pain, morphine, oxygen, nitro, aspirin. Oxygen decreases your oxygen demand. So it's not making you starve for each breath. Morphine is going to make you not be so desperate for oxygen. And that can be a huge comforting thing for families and for the patient. So yeah, you guys are all good. Very good. You guys are so smart. I feel like I did not know any of this. And then how do you have a goals of care discussion? So what are some things, like picture me dying, picture me, like what are some things that you would say to me if you just found out I got this terminal illness, just picture me as your patient, and what would you say to me? Don't say do you want us to stop aggressive care? What are some things? Go ahead.
I think I would just start off with like a general, like, how are you feeling right now? Or like, do you want to talk about what's going on and kind of see where they took the conversation first?
Right. I'm really scared. I'm really frustrated. What would you say then? Why nurse students in the back? Represent. Go ahead.
Ask them like their goals and like what comforts them.
Mm-hmm. Yeah, it's good. Mm-hmm.
You'd ask if they wanted us to call any family or anyone else that would make them feel more secure.
Yeah. Very good. So yeah, you're just gonna hope for the best, but prepare for the worst. So, I think if a patient was being dealt a terminal illness, you would not be the one having the conversation, but you will have, in your practice, you're going to be at the bedside with a patient who is suffering and they're really frustrated, and you're going to be the one who's trying to get them to wait for like their next test, or who's trying to talk to them until the doctor writes them for more pain medicine. So you're going to be the one at the bedside talking to these patients, and you might come up on the middle of the night and you're the one at the bedside. So I had a patient, I was only a few years out of nursing school, and she had pulmonary hypertension, and it was 2 o'clock in the morning, and she was on 100% non-rebreather, so the most oxygen I could give her without intubating her, and her pulse ox was 75%. So I had to say, like, when I call the doctor, which I had been calling the doctor all night, but your next step is to be intubated. Is that what you want? So it does come up. It might seem like you might never have that conversation with someone, and it seems like such a serious thing. How could they ask you to do it? But it totally comes up a lot more often than you think it would. So you say things like, I can't get your oxygen level up with my tools. I think that your next step might be to intubate you. What do you think about that? How do you feel? You're going to engage the patient and family with open-ended questions. So this is just a great way to start the conversation. And usually it kind of takes off from there. So what are you hoping for? What are you afraid of? What is quality of life to you? I've asked patients before, like, what do you think is a good death and what is a bad death? So what would be a good death to you guys? I know you're not thinking about this because you just want to get through your next test and you want to graduate. But like 60 years down the road, what's a good death to you guys?
Close your eyes and never wake up.
Yeah. I'm going down with my cats. We have a plan. I can't live without them.
Just like one without pain and with like my loved ones around me.
Yep. Yeah, it's a good one. Anyone else?
Like being mentally there.
Yeah. You don't want to wait so long that you can't know what's going on. Anybody else have like a good death idea?
I would just want to have my dignity intact.
How so?
Well, I guess like just from today, I talked to 2 patients, and one woman was saying how often she's referred to as like Hunter Sweetie in the hospital, and she's like, I don't feel like trusted. Like I don't trust you if you don't even take the time to know my name. Like don't call me Sweetie. So like just having the patient, like the nurses like know my name, and then like my other patient has like really bad diarrhea, and he's like, I'm just so embarrassed. Like I don't want to have any of that going on.
Yeah. What about a bad death? How would you guys? Because you don't want this first conversation to be with your patient at 2:00 in the morning. What do you guys think a bad death would look like? Go ahead.
If someone didn't have their affairs in order, and like say their family had to choose like if they needed to be intubated or not, and, like that can bring up family issues.
Mm-hmm. I had a lady tell me one time she had to talk to her sister because her sister had to go and delete a bunch of stuff off her laptop. I'm not kidding. Like, she was on a morphine drip, and she was on palliative care, and she was like, no, here's what you're going to go delete off my computer when you go. What else? Yeah, you don't want any incriminating evidence. What else? What else is a bad death? Go ahead.
Like being in pain and like not being able to say goodbye to your loved ones.
Yeah. Yeah, it's a good one. Anyone else? Go ahead.
I wouldn't want like every tube and wire possible like on me. Like I would want to like get rid of anything that wasn't necessary at the time.
Yeah. I teach clinical for Villanova, and we just did our CEIs last week.
Oh.
And one of my students wrote in her CEI that she would not want to be intubated, and I was like, "You're like 26 years old." Like, I think I wrote in there as my comment, like, "What if it was a reversible setback? Like, I'm gonna want to do CPR on you. You're 26." So yeah, some people just really don't want all those like tubes and drains. Totally. So very good, guys. Thank you for participating. So questions to avoid are negative statements that make the patient feel abandoned, like, do you want us to stop all aggressive care? And just avoid medical jargon, because patients don't like that in general, and then when they're like about to die, they really don't want to hear how smart you are. So then you're just going to give the patients the power. So we've talked about this. Your goal is you don't want to be intubated. So, and then you say, in order to meet this goal, I can give you morphine so you're not struggling to breathe. And then you just tell them, if at any point in time this doesn't work for you, or you don't feel right about it, or you don't feel good, then just let us know. We'll change it. So putting the power in their hands. Our jobs are all about the patients, so especially at this time, just give them all the power. And what are you responsible for as a nurse? You're just managing the symptoms. So giving the pain medicine, I love it. I've taken care of a few people on the floor when they were dying. In the ER observation unit, I had a patient die last year who was on palliative care, and it was just super rewarding. You're just making the patient comfortable, bringing the family in, getting them drinks, setting up little fruit trays. Like, you are completely in power now. The patients, you want the patient to have the power, but you're the one who's driving stuff. You're the one who can make or break this experience, because the doctor doesn't want to be there, because they're not gonna. They want to go see their other patients that, are doing well or that they can do stuff for, And then it just ends up being you left at the bedside with the patient and the family. So you're going to ask the families if they want to speak to a chaplain or the priest and help the patients to meet their goals and be creative. So have any of you helped a dying patient meet their goals? Anyone? Or even if it was like a family member, or even just like a really sick person. Go ahead.
Our junior year, during our med-surg rotation, we were on 4 Cathcart actually. I had a patient who was there for like an abscess or something, but he had cancer, and he had like the palliative team consulted, and his main goal was that he wanted to like reconnect with his daughter because he felt like through his sickness he had like lost touch with her, and so he's like, I don't know what to do anymore. Like, we used to go hiking, we used to bike, we used to like do all these things outside, and I was like, all right, like let's sit down and we'll make a list of your favorite types of movies. And so we made this entire list of movies for them to watch, and he was like so excited when she came in to like share this movie list with her, and she was all happy. So I think it helped him.
Yeah, give him something to talk about. Because I think it would be really scary if I hadn't talked to my daughter in a really long time, and now she's seeing me, and it's stressful, and you don't have anything to talk about. So you gave him something to talk about. I think that's pretty cool. What about some of my experienced nurses in the back? Have you done anything for a patient?
Yeah, we had a couple that fell in a car accident. The husband ended up as a vent-dependent quad, but the wife had pulmonary contusions, and he decided to make her comfort care when she got readmitted to the ICU. We actually brought his bed into the room and bagged him until she died, and then set it up for Skype for her funeral with nurses in there keeping company.
That's pretty cool. And I bet it was nursing really that drove that, not so much physicians, right? Your preceptor's so cool. Like, you're the one, you can make or break this experience for them. Go ahead.
A lot of times just bringing your pet, a dog or a cat. You'd be surprised how much that can mean to the patient.
Mm-hmm.
End of life, especially working in critical care.
Yeah, because they're in this stiff, miserable environment where they can't even have fresh fruit sometimes. And being able to have their pet at the bedside will really make them feel good. Anyone else? I had a patient one time, and he had throat cancer, and he was NPO for months, 6 months. Ridiculous. And we finally, it was 10 o'clock in the morning, and the doctors finally wrote the palliative care orders, and I was like, what do you want to drink? This is your first time you can have put anything in your mouth. What do you want? And he was like, I want a Coke. And I was so excited to go and get him little green sponges and let him taste Coke. I think there was 4 or 5 nurses in the room just seeing how excited this guy was to taste Coke again. It's it's cool to be in the ER and do trauma and put in chest tubes and stuff, but this is really cool too. I love it. Anybody else? Anybody else do anything cool for someone dying? No? All right, well, thank you guys so much for participating. We're almost done, I promise. So some things to think about. Every single one of our patients is going to die someday. You're not going to make it less sad. There's no perfect words or phrases or gestures that you can do that relieve how horrible it is. But a lot of times just being present, because you kind of know, you'll know what's going to happen. So sometimes just being that person in the room with the family to be like, no, this is normal. This is what we expect to happen. Or giving the family permission to do something. Why don't you hold your mom's hand? And that they're so scared to touch them because this thing is so foreign to them passing away. But you can just be the one in the room to be like, just hold her hand. And this is just last thoughts. And this was a quote. So presence may in fact be our greatest gift to these patients and their families. So you might think, oh, why would they want me in there? Like, that can be your gift to them, is being present. I've had patients who they were left alone on my floor to die, and nobody was there. And in the end, I was the only one in the room with them. They probably didn't even know my name. They might not have even cared because they were asleep, or they were actively dying, so they might not even have known I was there. But I was there, and I didn't let them go alone. So that's it. We already went over the quiz. That's all my work. Any questions? Do you guys have? Thank you guys for staying and participating. And for all the educators. Thank you for coming and making me feel not alone.
You did a great job.
Yeah.
I learned a lot.
Great.
I really did.
I think the biggest strength. You don't even know. I've been planning it for months.
Great.
All right, cool. Thank you guys.
Yeah, he's ridiculous.
Oh, thank you.
Tear up every time we talk.
I'd be the worst.
I just hit a button.
I cried. I teared up once. About like a guy talking about like how his son died. Like,
I just love your slides.
Yeah, they're good.